Morning, guys. Hope you all had a good Labor Day weekend. I just wanted to do a quick recap on our discussions from this past week. We sort of looked at back pain from a big picture level, and I think it's important because back pain is so common that we want to start to consider, all patients coming in maybe to primary care or for us, direct access, the triage process. So we can triage back pain patients in a number of ways. Probably the biggest one would be, are there red flags or serious conditions? Is there signs of a radiculopathy, or is it simple mechanical back pain? So we can break those patients up into three categories where our red flags are going to be 1% or less. Our patients with a radiculopathy are probably going to be maybe another 5%, and then the vast majority of our other patients are going to be the garden variety mechanical low back pain. So that's a good triage process to start with. Then after that, we want to maybe start triaging patients based on whether we think they're going to make a rapid recovery or not. So a fair percentage, particularly if they have acute back pain, it's recent onset, maybe they've had it before, but in between episodes they have no back pain. A vast majority of those we'd consider low risk and are probably going to get better with very minimal intervention. Likely these are not patients that show up at PT. They may or may not. If they do, these are patients that we don't want to get in the way of them getting better. So we would maybe do some simple hands-on things, some exercises and some advice, and those patients we would expect to recover pretty quickly. The type of patients that we tend to see, because we're not generally working in primary care or even direct access, are going to be your higher risk patients. So if you look at some of the studies on the risk of developing chronicity, about 30% or 1 in 3 come into primary care at risk for chronic low back pain. I think that's probably going to be even a higher percentage of the patients that are actually funneled to PT because we're secondary providers. So a lot of those patients that get better on their own, they either don't come in or they're not referred to PT. So just have to kind of think about that. The majority of our patients that we're going to see probably have some sort of risk factors for chronicity. Does that mean that they're all going to go on to develop chronic pain? Absolutely not. But that's why I wanted you guys to start thinking about how do we screen for some of those psychosocial factors. Some of it can be done through questionnaires like the Start Back tool, fear avoidance questionnaire, the Arebro, and then others would come from the interview. Some of the biggest things that you can ask as part of the interview is what their own beliefs are about their back pain. What do they think is the cause of their problem? How fearful of it are they? Are they avoiding activities? Are they distressed by it? Do they have work and family support? So some of those yellow flag questions, we want to be doing that with all of our patients with back pain because it's so prevalent, and we know that psychosocial factors are much more predictive of a poor outcome compared to any physical factors. In fact, there are no physical factors that are predictive of back pain outcomes, and that includes imaging findings or any other sort of physical impairment factors that we might see. So I thought you guys did a good job with that, describing your own triage process and how you might start to do a little bit of a better job starting to screen right off the get-go for these psychosocial factors. And I think all of us at this point, you probably can start to pick up on those quite readily, where you can get a sense from that initial evaluation as to who's going to be sort of making a rapid recovery or be sort of a recovery that's going to be quick versus those patients that are going to take a little bit more time. You might need to take a different approach, and they might not have the best outcome. And I think we can start to identify those people. What we're going to be talking about in subsequent weeks is if we do identify some of those risk factors, how do we adjust for that? What do we do with our interventions? We definitely have some good evidence for that. Does it work all the time? No, but I think the first step is being able to identify those yellow flags. So once again, to recap, we want to triage, screen for red flags, separate those other folks between sort of radiculopathy versus mechanical back pain, then start to look for risk factors for poor recovery. So good job. And then this week we're going to be talking about some of the bread and butter techniques for back pain using a case. So I'll look forward to your responses to that.